Hello, good evening, everyone. Welcome you all for day two live webinar that is on Precision Oncology 2025 and beyond. For the welcome and introduction setting, I would like to invite Program Convener Dr. R.K. Chaudhary, sir. Sir is Director and Head Medical Oncology, Hemato-Oncology from Metro Hospital, Delhi. Over to you, sir, for welcome note.
I'm not able to. Okay. Hi, good evening, everyone. Good evening, Dr. Vedant, sir.
Good evening.
Hi, sir. How are you?
All good, Dr. Chaudhary. How are you?
Yeah, I'm good. So, once again, welcome to the day two of the this webinar. So, today we are going to discuss about the breast cancer, gynae cancer, and we are also going to discuss about the supportive care. And there is a panel discussion on the breast cancer. Right. So, for the first talk, I would like to invite Dr. Vedant Kavra, sir. He is a principal director in the Department of Surgical Oncology at Fortis Memorial Research Institute, FMRI, Gurgaon. Sir is going to deliver his talk on INSEMA trial, where the no axillary surgery versus sentinel lymph node surgery and final outcome. Dr. Vedant, sir, please.
Thank you, Dr. Chaudhary. I'll just share my screen and the slides. So I hope my slide is visible to you.
Yes, sir. Yes, sir. Perfect.
I'll be reviewing this paper, which was presented in ASCO last year. So basically, a background is that SLNB is a very reliable means to avoid ALND and its morbidity. We all know, like lymphedema and shoulder problems. Now, there are trials which have said that SLNB in upfront surgery setting, if there are few nodes positive, then we can still avoid ALND. And we also know from the Society of Surgical Oncology US Choosing Wisely statement of 2022 that a lady who is more than 70 years has a T1CN0 lesion, ER positive, HER2 negative, we can safely omit axillary surgery altogether. However, we didn't have any randomized trial for that. So the questions to be answered are, is axillary surgical staging needed in clinically N0 patients who are undergoing upfront surgery? And can imaging replace surgery for a reliable axillary surgery staging? There are 4 trials, 2 of them ongoing and 2 of them have already reported. Sound was presented in St. Gallen's 2023 and it reported non-inferiority of omitting SLNB in tumors which were less than or up to 2 centimeters upfront surgery. INSEMA is an intragroup study which I am going to review, and there are 2 more trials which will report results possibly this year and then a couple of years later. In INSEMA group, it was a multicentric non-inferiority RCT, 142 sites in Germany and 9 sites in Austria, with regulatory coordination happening from Austria. More than 18 or above years of patients, T1, T2, clinically N0 and imaging-wise N0. And imaging was in most patients ultrasound. There was 1:4 randomization of no axillary surgery versus SLNB. And if SLN were 1 to 3 positive, then there was a second randomization of ALND versus observation. But we will not be discussing this because the results of this trial, this part of the trial is not yet out. And in form of local treatment, if the imaging had a suspicious node, then FNAC and core biopsy needed to be done and negative, and only then the patient would be randomized because we needed N0 axilla. BCS with whole breast RT with boost of the cavity was needed, and axilla was specifically not targeted. So this was a problem with ZOO11. Here it was said that no axillary tangent should be there. APBI was not allowed, and the central review of first 3 cases RT was done. So at each center, the first 3 cases, how the RT planning is done, it was centrally reviewed to specifically see that the axilla has not been radiated. The primary outcome was in invasive disease-free survival, which included ipsilateral, death from any cause, contralateral invasive breast, or any invasive cancer apart from breast also. And the secondary outcomes were overall survival, locoregional disease-free survival, distant disease-free survival, quality of life measures, and RT dose at the axillary levels. And these 2 quality of life scales were used. The sample size was calculated based on IDFS expectation of 88%, 5-year, And in the surgery omission group, they wanted at least 85% 5-year invasive disease-free survival. And the upper end of the 95% confidence interval should have been less than 1.27 for it to prove the non-inferiority. They expected 850 events, primary outcome events, and the per protocol size calculated with was 5230. Presuming a 5% exclusion, they wanted 5,502 patients to have a power of 80% of non-inferiority. And if there was a lower event rate, then they would do they actually there was a lower event rate. So they did a time-driven analysis at 5.5 years of follow-up from the last randomized patient. This is the flowchart of the trial. 5,502 patients were included, but there were dropouts because of various reasons, including some of them undergoing mastectomy. So finally, randomized were 5,154. Again, few of them were excluded because of certain indications, and the per protocol set was 4,858 patients. It was nearly there, but not enough as per the initial calculation. These are the various methods used for statistical calculation. I'm not going in details. From 2015 to 19, they recruited 5,502 patients. 5,184 were in the intention of treat analysis and 4,800 something in the per protocol analysis. Baseline characteristics were matched. Median age 62 years and only around 11% patients were below 50 years. You see the median size, in spite of having T1, T2 tumors, they had a median size of 15 mm by palpation, and the actual median size by imaging was only 11 mm. 90% patients were T1 clinically, while final pathology showed that nearly 80% of them were T1, so only 20% were T2. Even in the subgroup of T2, the median size was 25 mm, so they were all early T2 mostly. 15% of these patients who underwent SLNB were having SLN node positive. These were the baseline characteristics. They were matched. Coming to invasive disease-free survival in the per protocol population, and you don't find any difference. It is 91.9 in no surgery group versus 91.7 in the surgery group. And HR ratio also remaining less than 1.27. So non-inferiority was proven here. Now, if you come to loco-regional recurrence, you find that axillary recurrences were higher, which is expected also, but it was not statistically significant. Per protocol overall survival. So the previous one was invasive disease-free survival. This is overall survival, which was one of the secondary endpoints. This is invasive disease-free survival, intention to treat. So per protocol, we saw no difference. Now, intention to treat population also, no difference. When you come to surgical complications or quality of life, lymphedema, as expected, was less in the no surgery arm, but was not very high, only 5.7% in the SLNB arm. And same was true for shoulder arm mobility restriction or painful shoulder movement. But the difference was not too much. So the discussion points are, although in the SLNB group, we found that 15% nodes were positive, but the cumulative axillary recurrence in no surgery arm was only 1% at 5 years. And we know this even from pre-SLNB era, that the ALND actually did not improve the outcomes or did not lead to very high local recurrence or regional recurrence rates, because systemic therapy and possibly radiation therapy also took care of those small disease found in the sentinel node biopsy group, which were positive. Now, the other problem is in younger patients, sometimes nodal status becomes significant. For example, in RxPonder, we know that the chemo advantage is not ruled out in low or intermediate risk groups. And if node positivity is there, then it will change the treatment. Similarly, extended hormone therapy or ovarian function suppression is done in node positive high risk patients. So here we probably need to know the nodal status, and we can't really avoid SLNB altogether. Now, even radiation is adaptation based on nodal status. So if you have a node positive SLNB only, then RT can be escalated as in Amaros trial, as against doing completion ALND. If old patient is there more than 65, in some selected patients, node negative disease, early disease, no RT, maybe, RT de-escalation can be done. Now, what is the reliability on USG to detect nodal involvement? There is a meta-analysis where we found a sensitivity of ranging from 25 to 95 nearly. But in the current study, the sensitivity was much higher. It was clinically meaningful because these 15% METs were micro and macro, which was much lower than the previous SLNB trials like Milan and NSABP B32. So the sensitivity of USG here was good. And the extensive nodal involvement, which is defined as 4 or more nodes, was only 0.2%. So very small, minuscule percent of these 15%. And the cumulative axillary recurrence, as we discussed, was only 1%.
Sir, sorry for intervening. Need to conclude, please, sir.
Okay. So these are the final discussion points. Okay, I'll just come to the last slide only. There are certain limitations that it was restricted to very good group, very uh, small tumors. So they concluded that there is non-inferiority of omitting SLNB in early breast cancer N0 patients undergoing BCS, and 5-year overall survival was same. But what they recommend is it can be used for more than 50 years, T1N0, grade 1 to hormone positive, HER2 negative group, because that is the group which formed the major group. It is a well conducted RCT, only BCS per protocol analysis was there, but the ITT was also same. And in Indian context, the problem is of reliability on the USG, and we have a larger tumor size mostly. So small tumor size, very good ultrasonologist, maybe we can consider. And in SEMA did show better quality of life, but ideally it should have been the primary endpoint rather than a secondary endpoint. So it is probably applicable to a very select group of patients where we may consider it. Thank you. And since this was a very low risk group, a long term follow up is needed. Just a 5-year follow up may not do. Thank you.
Thank you so much, sir, for your excellent talk. And we'll move for the next talk. So for the next talk, we have Dr. Bhuish Saxena, sir. Sir is consultant and head Department of Medical Oncology, Manipal Hospital, Gurugram. And sir will present Supremo clinical trial. Over to you, sir.
Very good evening. My slides are visible, and I
Yes,
am
sir. Perfect. Yes, sir. Perfect.
so thanks, Chaudhary sir, for giving me the opportunity. Thanks, organizer. So topic given to me is, does post-mastectomy radiotherapy in intermediate risk breast cancer patients impact overall survival? We are going to discuss 10-year results of the big 204 MRC randomized trial on behalf of Supremo trial investigator. So this is the concept. Of course, we know it very well that what does it mean from intermediate risk. So to begin with, we know about this trial that's, of course, established the role of radiotherapy in overall survival, that was published in NEJM in 1997 by Nation Canadian Group. So what they showed that in the high risk group, if we add radiotherapy to a CMF chemotherapy, there will be benefit. There will be a benefit in terms of overall survival, which is almost 9%. But in this trial, they have taken a high risk group as a with all patient with a size of 5 centimeter or more, that's T3 or more, or they have taken I node positive. So, but among those high risk group, many of patients were intermediate risk group. So, say idea is that, and of course they have used CMF chemotherapy, which we know that CMF is not a standard of care anymore. We have much better options. Science has advanced a lot. So this trial has certain limitations. So still, if we continue to follow the radiotherapy to all those node positive patients and say 5 centimeter more, that's not correct. So idea is that we should know at least in the N1 subgroup, that's when nodes are 1 to 3 positive. So those patients are not that much prone to say recurrence and how much the radiotherapy is going to offer survival benefit for them. That's the question. So this in the big 204 trial, the Supremo group tried to analyze that whether these intermediate risk patients are going to actually benefit from this adjuvant radiotherapy or not. And of course, we are talking about post mastectomy because in BCS we anyhow give the radiation. That's not a question. So, what are the intermediate risk patients? These are either T1N1 or T2N1 or T3N0 with, of course, a histologically confirmed invasive breast cancer, or T2N0 but grade 3 or a lymphovascular invasion. So these are patients which are considered intermediate. Whether these patients are going to have any survival benefit with the adding of adjuvant radiation, that's the question. Of course, they have done the simple mastectomy. Now, if we have taken the patient as a node positive, then axillary node clearance is a must, and 8 nodes should have been removed. But axillary node negativity can be based on either axillary node clearance or even every node sampling or sentinel lymph node biopsy, all are acceptable. So that's the practice which we are following. And of course, adjuvant or neoadjuvant chemotherapy or adjuvant hormone therapy was given as per, of course, the standard protocol, and consent should be there. So they have given the chest wall in the radiation. So that was in a dose of 50 gray in 25 fraction over 5 weeks, or there might be some equivalent dose. They have included the patient with the 45 gray in the 15 fractions over 3 weeks. And the question is, they have taken these patients as they have not given radiation to the axilla. They have given to the radiation to chest wall only, and of course they have included the patient who have the, of course, the internal memory nodes that were included. So, what was the endpoint? Primary endpoint was OS, and secondary were local and regional recurrence, distance-free and metastatic-free survival, cause of death, acute and late morbidity, quality of life, and cost effectiveness. Now, of course, 1600 patients for the 80% power. That was the idea, and to get the significant difference at the 5% level, if the delta is 7% in the OS. So, if we find that the 7% difference is 7% or more, then we will take that, of course. Omitting chest wall radiation is not a great idea. And they require, of course, 609 events. That's that. So they have randomized 1,679 patients. The experimental arm without chest wall radiation have 834 patients, and the, of course, conventional arm with the chest wall radiation have 845 patients. And after exclusion, in the ITT, in the no chest wall radiation arm, they have analyzed 799 patients after dropout and withdrawal. And in the chest wall radiation, they have analyzed 808 patients. So data log was 19 June 2024, and of course, as I have told you about the radiation part. So the baseline characteristics were well matched. We know it very well that, of course, it's not about they have only 25% patients were node negative, so almost 75% patients were node positive. So there are sizable number. Of course, all four varieties which you have taken, they have almost 25, or say they have significant proportion. Of course, the T3N0 is slightly less. And but it's not about the only hormone positive biology. They have taken the patient with the HER2 new positive. 20.6% patients were HER2 new positive, and 10.8% patients were triple negative. So it's not about that they are trying to select the only good biology of hormone positivity. And if you look at just and now if you look at the endpoint, then the primary endpoint was overall survival, and you can look at that. Of course, the with this graph that the red line is for showing the patient without chest wall radiation, and blue line is showing the patient with chest wall radiation, and both lines are overlapping. So you can see the hazard ratio was 1.04, and p-value is 0.79. So it's not significant. There is no significant difference in the overall survival with the omission of chest wall radiation in these patients. You can see in the without chest wall radiation, there are 18.1% death, and with chest wall radiation, deaths were 18.6%. So of course the delta is only 0.5%, though the expected for the difference they were expecting for 7%. So this point was met. Now if you look at that whether overall survival in the node positive or node negative, then in the both subset of the patient, you can see that the curves are overlapping, and the hazard ratio is 1.21 for the node negative, and hazard ratio is 0.97 for the node positive. So that doesn't matter that whether the node positive or negative, the overall survival remains same. So adding chest wall radiation doesn't improve overall survival after 10 years in this intermediate group patients. Now, if you look at the secondary point, then of course you can see that the blue line is above as per expectation. That's if the patient is the experimental arm is less, so red line is so there is hazard ratio of 0.45. And if you look at the events, then in the with chest wall radiation there are 1.1% recurrence, while without chest wall radiation 2.5% recurrences. So there is difference of 1.4%. So there is definitely significantly difference that omission of chest wall radiation impact the chest wall recurrence in a negative way. The recurrences are more if we omit the chest wall radiation, but the delta is only 1.4%. Of course, the hazard ratio is 0.45, and p-value is 0.04, but delta is only 1.4%. Now, how would you like to interpret this? It's up to you. But the author says that it's clinically no, insignificant or not meaningful. Now, of course, as per expectation, chest wall recurrences in the node negative, there is curves are overlapping. The hazard ratio is 1.13, and p-value is 0.9. So there is no difference. The whole benefit is derived from patients who are node positive. Now, similar
Oh,
results
right.
I found with in the patient with regional recurrence.
अच्छा.
The with the similar result are that blue curve is better. So if we omit the chest wall radiation, then of course renal recurrence will also increase. The hazard ratio is 0.61,
Sir,
and
sorry for intervening, sir. Need to conclude, please, sir.
okay. So of course, as per expectation, the regional recurrences are more in the node positive group, and of course they are negligible in the node negative group. And the same story with, but here if you look at the metastatic free survival and disease free survival, then again the curves are overlapping. There is no difference. The hazard ratio is 1.06 in the for the MFS, and it is 0.97 for the DFS. So there is no difference in metastatic free survival and disease free survival in if we omit which HVAL radiation in these intermediate patients. So to conclude, in patient with 1 to 3 positive nodes or node negative with other risk factor like T3 or say maybe LVI positivity or maybe grade 3, the adjuvant chest wall irradiation with optimal systemic therapy does not improve 10-year overall survival. So curves are absolutely overlapping irrespective of node negative or node positive. Overall survival remains same. It results in clinically insignificant reduction in 10-year chest wall recurrence. That's almost 1.4%. This is less than 2%. Of course, though that is though statistically significant, but maybe clinically insignificant. There is no impact on disease-free or metastatic-free survival, and there might be incremental improvement in multidisciplinary care. Probably explain the results. There are a lot of improvement in the systemic therapy. So adjuvant chest wall radiation should be omitted in most of the patient meeting the eligibility criteria for Supremo. So that's to conclude. Thank you.
Thank you so much, sir, for your excellent talk. There is a slight change in the schedule, so we have now we have AP Dubey sir's talk. So I would like to invite AP Dubey sir. Sir is senior consultant, unit head, medical oncology, hemato oncology, Metro Hospital, Delhi, and sir will talk on will present the abstract Olympia trial. So over to you, sir.
So good evening to all. And at the outset, first, I would like to thank the organizer and Dr. Chaudhary for giving me this opportunity. Can someone present the slides for me? So I'll be presenting the pre-specified analysis of invasive disease-free survival and distant disease-free survival and overall survival 10 years from the first patient in the Olympia trial, that is about addressing the role of adjuvant olaparib in germline BRCA1, BRCA2 mutation-associated breast cancer. Next. 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 Okay. So as we all know that how these PARP inhibitors work, like whenever there's application of the synthetic lethality, that is application of defect in single-stranded repair, that is application of PARP inhibition in the cells with the background defects in double-stranded DNA repair, will ultimately lead to the cumulative death of the cell. That is the principle of synthetic lethality on which PARP inhibitors actually work. This is the Olympia trial schema where the patients of early breast cancers were randomized either to olaparib 300 mg twice daily for a year or placebo. And who were the patients? Either in the neoadjuvant group, who in triple negative group who did not achieve PAT-CR with neoadjuvant therapy, or in hormone receptor positive group who had not achieved PAT-CR and CPS EG score was greater than or equal to 3, or in adjuvant group who were in triple negative or T2 or more or N1 or more pathological stage on surgery. And if we talk about hormone receptor positive, then patient would be having 4 or more than 4 positive lymph nodes. Next. And the primary endpoint was invasive disease-free survival and distant disease-free survival. These are the baseline characteristics, which you can see that they are comparable between the intervention arm, olaparib arm, and the placebo arm in respect of age and the alteration of which BRCA gene, menopausal status, primary breast cancer surgery. Next. and other characteristics like hormone receptor status, whether the patient is having hormone receptor positive breast cancer or triple negative, or patient has received prior neoadjuvant chemotherapy or had underwent upfront surgery. Next. So you can see this is the summary of the two-sided significance levels across the endpoint and analysis. And this is the third pre-planned analysis, which was conducted 10 years from the first patient in the particular trial. And median follow-up of at this point was 6.1 years, with the maximum follow-up of the first patient was 9.6 years. So you can see that the significant boundaries were crossed for invasive disease-free survival, distant disease-free survival, and overall survival. That is first interim analysis and the second interim analysis both. And no significant further testing were involved. You can see that final overall survival analysis, which was supposed to be done at 15 years from the first patient, was not been done. Next. So now if we see about the first invasive disease-free survival, talking about the number of patients with the first invasive disease-free survival event, that occurred in around 19.3% in the olaparib arm, whereas 28.2% the placebo arm. So olaparib arm doing well in the terms of distant recurrence, whether it was distant CNS recurrence or distance extracranial recurrence. You can see 11.5 or 2.8% CNS recurrence, as well as extracranial recurrence 8.7% in olaparib arm, whereas 4.4 and 11.9% in placebo arm. Here too olaparib doing well. And olaparib doing well in all regional recurrence, local recurrence, contralateral invasive breast cancer, second primary non-breast malignancy, and death from a prior invasive disease-free survival. In all these parameters, olaparib was doing well as compared to the placebo arm. Next. So now this is analysis of invasive disease-free survival in intent to treat population. You can see that at 4 years, the invasive disease-free survival, there was a difference, delta of around 8.4%, which has further improvised to 9.4% delta at 6-year invasive disease-free survival. Whereas you can see that in the placebo arm, that invasive disease-free survival is 70.3, whereas 79.6 in the interventional placebo arm, in the olaparib arm. Next. Now, this is subgroup analysis of invasive disease-free survival. You can see almost all subset, whether they received adjuvant, neoadjuvant, whether they received platinum or not, whether they were hormone receptor positive or negative, whether they were BRCA1 or BRCA2 positive, did achieve benefit with the olaparib as compared to the placebo. Next. So as per the invasive disease survival, as per the hormone receptor status, both irrespective of hormone receptor status, whether it was hormone receptor positive or triple negative, you can see the patient did achieve the benefit in the terms of invasive disease survival with a delta of around 10% in triple negative, and again a delta of around 10% in hormone receptor positive patients. Next. Now, a distant disease-free survival in intent to treat population, you can see that from 4 year to 6 year, there was improvement in distant disease-free survival from 7.5% to 7.8 year, with 75.7% in placebo arm and 83.5% in the olaparib arm, with the hazard ratio of 0.65, that is decreased risk of progression or death by 35%. Next. So this is subgroup analysis. Here also you can see the hazard ratio of most of the subset, almost all the subsets were less than 1, and irrespective of chemo, platinum, hormone receptor status, and BRCA1 or BRCA2. Next. So number of deaths occurring in olaparib arm, you can see that they were numerically lesser than as compared to the placebo arm, 11.6 in olaparib and 15.6 in placebo. And the primary cause of the death were, whether it was breast cancer or other, were lower in olaparib arm than the placebo arm. Next. So in intent to treat population overall survival, you can see the delta at 6 years was 4.4% with the hazard ratio of 0.72, that is 28% reduced risk of death with olaparib as compared to the placebo. Next. Now, subgroup analysis of overall survival. Here also you can see that the hazard ratio of almost everything except for whether patient is BRCA1, BRCA2, that they all were less than 1, and all these subgroup of patients were achieving benefit with olaparib. Next. So summary of the adverse events. Any adverse event leading to death were comparable between olaparib and placebo. You can see 1% in both. And the incidence of specific adverse event like MDS, AML, pneumonitis, you can see they were numerically lower in the olaparib arm, 0.4% in olaparib, 0.7% in placebo, pneumonitis 1% in olaparib and 1.4% in placebo, new primary malignancy 4.9% in olaparib and 7.5% in placebo. Next. Now, summary of adverse events of special interest, that is new primary malignancy, whether it was breast, ovary, pancreas, or other. You can see that all these malignancies tend to happen in lower incidence in the olaparib arm. You can see breast cancer happening only in 2.9% and 4% in placebo, respectively. And the number of malignancy 4.9% in olaparib and 7.5% in placebo. Next. So summary of new breast and ovarian cancer, that also you can very clearly see that 34% developing invasive breast cancer in olaparib, whereas 42 in placebo, and 5% developing fallopian tube or ovarian cancer, whereas 14 developing in placebo. So number of malignancies, whether ovarian or breast, were more in the placebo than in olaparib. So, talking about pregnancies and their outcome, you can see that it is the number of pregnancies were equal in both the arms, and even the outcomes, whether it was fulcrum, premature birth, spontaneous miscarriage, or termination, they were one or so there comparable in both the arms. So, the olaparib itself did not impact the number of pregnancies or outcomes significantly. Next. So to conclude Olympia trial, that at the 6.1 years median follow-up, that is maximum 9.6 years, 12 months of olaparib after neoadjuvant chemotherapy in high-risk patient or after adjuvant uh, uh, after upfront surgery and adjuvant chemotherapy has resulted in significant improvement in invasive disease-free survival, distant disease-free survival, and overall survival in patients with germline BRCA positive and high-risk HER2 negative primary breast cancer. And olaparib benefit, as we had seen in the forest plot, whether it is invasive disease-free survival or distant disease-free survival, was consistent across all the subgroups, including for patients with high-risk hormone receptor positive or progesterone receptor positive. And only fewer new primary malignancies were observed in olaparib arm. That too, they were numerically lower than the placebo arm. No new safety signals were observed, even though in the terms of there was no increased risk of myelodysplastic syndrome or acute myeloblastic leukemia. So this data gives us confidence and continue to support the adjuvant olaparib as standard of care in patients with germline BRCA positive, high risk HER2 negative primary breast cancer, and therefore highlight the importance of germline BRCA testing for treatment planning. Thank you.
Thank you so much, sir, for your excellent talk. We'll move for the next talk. So for the next talk, we have Dr. Rajat Govind, sir. Sir is consultant medical oncologist, Army Hospital, Delhi, and sir will talk on Platina trial. So over to you, sir.
Am I audible?
Yes, sir, you are audible.
All right. Thank you very much, organizers, for this academic feast of sorts regarding the latest of SABCS. So I'll be talking about the phase 3 Patina. May we share the screen if possible? Yeah. Okay. So we'll discuss the Patina trial, which was recently shown at the late breaking abstract in the SABCS, and which is randomized open label phase 3 trial which evaluated the efficacy and safety of CDK4/6 inhibitor palbociclib along with anti-HER2 therapy and endocrine therapy versus only anti-HER2 therapy and endocrine therapy, as is the standard of care as on today, after induction chemotherapy for the triple positive subset, as we know, hormone receptor positive and HER2 positive metastatic breast cancer. This is, of course, in the first line. So this is a very novel sort of attempt of adding CDK4/6 inhibitors upfront to the already existing standard of care. So this background we all know, so I won't spend too much of time. Just a point to note here, if you look at the rationale of choosing this novel combination, which included a CDK4/6 inhibitor in a subset of HER2 positive disease, the cyclin D1 CDK4 axis, which we all know is very essential for the initiation and maintenance of growth of the HER2-driven mammalian carcinomas. So the persistent cyclin D1 and CDK4 activity, which was shown to drive the resistance to the HER2 pathway blockade. So hence, there was a rationale that the combination of CDK4/6 and HER2 inhibition together may show synergistic anti-tumor activity in preclinical models. So palbociclib, is an approved CDK4/6 inhibitor, and hence it was tried in this subset of population. Next. So this I've already mentioned. This is the rationale. If you look at the HER2 and the CDK4/6 pathways, they converge at this tumor suppressor protein TSC2. So when CDK4/6 and HER2 inhibitors together are combined, there is a potential to suppress this RB phosphorylation and downstream pathways of mTOR, which enhances the anti-proliferative activity of this inhibitor molecule. So as on date, we know if you look at the left side of the screen, it is the palbociclib and AI or fulvestrant, which is the standard of care as far as the hormone receptor positive disease is concerned. And in your right, if you look at the HER2-driven CA breast, trastuzumab, pertuzumab combination is the standard of care after induction chemotherapy. So this is a novel sort of combination. Next. So this is the study design. It was a open label phase 3 study, which was conducted in triple positive breast cancer stage 4 patients. And no prior treatment was given in the advanced setting. So they were all first line treatment naive patients who have already received the standard induction treatment. Induction, as we know, which includes 6 to 8 cycles of trastuzumab, pertuzumab, along with either taxanes or the third agent. And the key eligibility criteria also included that these patients should be responsive to the induction chemotherapy. That is, they should have at least a CR, PR, or stable disease. And it was stratified, of course, with or without the use of pertuzumab, because as and when the trial started recruitment, the inclusion of pertuzumab became a standard of care. So the non-pertuzumab option was limited to just 20% of the population. Prior anti-HER2 therapy in the neoadjuvant setting also was a stratification factor, whether they did receive it or not. Response to the induction chemotherapy, of course, and the type of endocrine therapy also was stratified, whether we used fulvestrant or aromatase inhibitors. And these patients were then randomized. We had about 500 odd patients, 1:1 randomization, with palbociclib in standard dosage, along with trastuzumab or pertuzumab, with or without pertuzumab, and endocrine therapy in one arm, and the other arm just having the anti-HER2 and endocrine. So these patients were followed up till progressive disease or toxicity. Next. So the primary endpoint, of course, this was the study enrollment. Yeah. So the primary endpoint, of course, here was the PFS, and the key secondary objective was, of course, the overall survival. Next. Yeah. So it started in 2017, somewhere in the middle of 2017, and was completed till July of 2021. And the target accrual of about 500 patients, which is very impressive. And next. So this is the consort. If you look at it, 518 patients at the end were randomized to either of these arms. Next. So the key demographic features here, if you look at it, they're quite fairly balanced in both the arms. The most of the cycles, all of them had completed the 6 cycles of standard induction chemotherapy. Next, across all geographic regions. And here, if you see, most of the patients did receive pertuzumab, which had by then become the standard of care as far as induction chemotherapy is concerned. Most of the patients received aromatase inhibitor as the endocrine partner in the combination. And of course, the response to the first line induction, most of the patients did achieve at least a CR or a PR. So about 70% in both the arms did achieve either a CR or a PR. Next. So this is the primary endpoint. If you look at the curves, the primary endpoint of PFS, we do have a very impressive delta here. 44 months versus 29 months with a hazard ratio of 0.74. And if you look at it, this curves, most of them, if you see right from the beginning, they tend to separate. And this is what we expected when we started off with the standard anti-HER2 endocrine therapy arm. But the addition of palbociclib here definitely has achieved a meaningful PFS benefit. Next. If you look at the stratification via the pre-specified subgroups, most of them did show benefit towards palbociclib, so there's no denying here. Next. Yeah, the secondary endpoints of overall response rates and clinical benefit rates were also higher with the combination of CDK4/6 with the standard of care. Next. The interim analysis, the final data for overall survival is yet to be measured. But if you look at the secondary endpoint at the interim analysis, did show a slight increasing trend towards the favoring the palbociclib arm, but still long way to go. Here, if it's too early to say really that there's any clinically meaningful overall survival benefit with this, which will be interesting to see at the end when they do publish and come out with the proper data, whether this combination does have an overall survival benefit. Next. So another important thing that we need to consider whenever we have such kind of addition of two different classes of drug acting in the metastatic setting is the quality of life. And in that quality of life, the most important considerations given is that of toxicity. And if you look at it, there is not much of difference with the addition of palbociclib. We do know that the addition would definitely give rise to some bit of neutropenia, but if you see, and that is expected that about 60% or 63% to be exact did have about grade 3 neutropenia versus just about 4% in the standard of care arm. So neutropenia is a matter of concern, yes, but did that lead to treatment discontinuation? That we need to see. But as far as the rest of the side effects are concerned, most of them, as expected, were marginally higher. But if you look at the grade 4, grade 3 events, they're not much more than the usual arm. So this is sort of expected in the subset of population that we are studying with the inclusion of these two drugs of different classes. Next. So conclude, these results do have a strong scientific rationale. We must acknowledge that fact that this combination, at least theoretically, does overcome the resistance to anti-HER2 therapy and endocrine therapy by the addition of the CDK4/6 inhibition. The addition of palbociclib to anti-HER2 and endocrine therapy in this trial did show a significant improvement in PFS in the metastatic setting in the first line, and hence this does have a potential to become a standard of care later on, if and when the benefit is extended into the overall survival as well. As of now, the toxicity profile is manageable. We do not have something new or surprising that has turned up as far as the safety profile is concerned, so that is encouraging. So in the end, it's quite an interesting trial, and we must keep our ears glued for a more detailed criticism and applause of this trial as and when the data matures. So that'll be all, please. Thank you.
Thank you so much, sir, for your excellent talks. For next, we have one talk left, and that is by Dr. Avinav Navaria, sir. Sir is consultant medical oncology, Manipal Hospital, Delhi, and sir will talk on Natalie trial. Over to you, sir.
Hi, good evening. Do I have to share the screen or will you share the screen?
Sir, if it is possible, you can share. Otherwise, we'll do so.
Wait, let me. Please share it for me now.
Okay.
Good evening, everyone. So today I'll be presenting long-term data of Natalie study, which was presented in SABCS 2024. So it has shown durable reduction in distant recurrence in broad population of patients with early breast cancer. So as we all know that abemaciclib has holded its position in early breast cancer, and other two CDK4/6 inhibitors are also trying. So this is a study in which they have presented their long-term distant disease recurrence-free survival. So despite improvement in the outcome of patients, there is always a worry that if the patient recur distantly and it becomes stage 4, then there is no cure. So in the Natalie's trial, distant disease-free survival was improved with ribociclib and an NSAI versus NSAI alone in patients with stage 2 and 3 hormone positive early breast cancer. So the distant disease-free survival benefit was maintained with all the patients of ribociclib. So even if you finish the ribociclib, the DDFS benefit was carried on. Given that risk of distant recurrence can depend on various disease features, assessing the effect of current adjuvant treatments on distant recurrence-free across patient subgroups, so including by stage or nodal status, it is very important for the treatment selection. So in this study, they have presented the overall distant disease-free survival and distant recurrence-free survival across all the stages and nodal groups on the 4-year landmark. So this is a study design. Adult patients with hormone positive and HER2 negative early breast cancer were taken. Prior ET was allowed less than 12 months prior to randomization. So anatomical stage 2A, that means N0, but in N0 they need grade 2 and evidence of high risk, that is Ki67 of 20%, or if you have done oncotype DX, so score should be more than 26, or high risk via genome risk profiling, which we are doing, which we all have started doing, or grade 3, and then N1 or N1, N2, N3. So 400 mg of ribociclib, 3 weeks on, 1 week off for 3 years, plus NSAI, letrozole or anastrozole, along with OFS if required, versus letrozole or anastrozole for 5 years. So primary endpoint was in interval disease-free survival, invasive disease-free survival. Secondary endpoints were recurrence-free survival, distant-free survival, overall survival, and next slide. So here, if we see at the data cutoff of April 29 with all patients of ribociclib treatment, ribociclib plus NSAI. So they have, they have given for 3 years. This is data for 4th year. So of ribociclib treatment, a distant disease-free survival was benefit in the intent to treat population was maintained. Median duration of follow-up was 44.2 months. Distant recurrence-free survival was also improved with ribociclib plus NSAI versus NSAI alone, and a hazard ratio of 0.7. So here you can see the Kaplan-Meier curves for distant disease-free survival as well as distant recurrence-free survival. The hazard ratio for distant disease-free survival is 0.7 versus in distant recurrence-free survival it is 0.7. So it is showing some benefit. Next slide. So now we will see where the most common sites of distant recurrence happened. So as we know, in hormone positive, the bone is the most common site. Then comes liver, then lung, and then lymph nodes, CNS. So you can see the more number of metastasis happened in NSAI alone bone metastasis 109 versus 142, and the same trend continues in everywhere, that more recurrence were seen in NSAI alone arm. Next slide. So if we see by distant disease-free survival by stage, a constant distant disease-free survival benefit was observed regardless of anatomical stage. If we see stage 2A, stage 2B, there is consistent distant disease-free survival. So here in stage 2A, the hazard ratio is 0.3. In stage 2B, it is 0.8. Next slide. In stage 3A, it is 0.6. In stage 3B, it is 0.56. We can see the graphs keep on separating. Next. And in stage 3C, the hazard ratio is 0.878. So we can see in earlier stages, the distant disease-free survival is more. Here you can see a chart where you can see in stage 3B, it is the 3-year absolute benefit was 6.8, and it continues and it increases even after ribociclib has been stopped, and 4-year absolute benefit in stage 2A is 5.1, stage 2B it is 2.6, stage 3A 4.6, stage 3B it is 11.4, and in stage 3C it is 4.5. Next slide. So if we see distant disease-free survival by nodal status, we can see the distant disease-free survival in N0 and N1 to N3. In both N0 means nodal node negative as well as node positive, both are benefiting. The DDFS in N0 is 0.69, whereas in node positive it is 0.726. So a little benefit is there even in the node positive disease. Next. So again, in N0 it is 2.7, in N1 to N3 it is 2.4, 3-year benefit, and see, you can see even after that it continues. It at 4-year it is 4.2 versus 4.6. So distant disease-free survival by menopausal status, Ki67 status, age group, and prior ET duration. So you can, if we analyze a little bit in deeper, in young women it is more, the absolute 3-year absolute benefit is 5.5, and in 4-year it is 8.1. So younger female, we can not definitely conclude, but you can see that there is more benefit in younger population. In Ki67, by stratifying on Ki67, it is almost equal. So every group is benefiting by the 4-year survival absolute benefit remains even after stopping ribociclib. So key finding in conclusion, a 4-year landmark analysis was performed in Nutley when all patients were off ribociclib. The combination of ribociclib plus NSAI consistently reduced distant recurrence in patients with hormone-positive breast cancer, including N0 disease. The distant disease-free survival and distant recurrence-free survival benefits in the intent to treat population across all subgroups were maintained beyond the planned 3-year ribociclib duration. In all subgroups, the absolute benefit with ribociclib plus NSAI versus NSAI alone increased from 3-year to 4 years. So the results were consistent. These findings support the use of ribociclib in combination with NSAI in the adjuvant setting to reduce the risk of distant recurrence in a broad population of high-risk patients with hormone-positive, HER2 negative early breast cancer. So we do have another option rather than abemaciclib, and patients who are not tolerating abemaciclib on because of a lot of diarrhea, we have other options in form of ribociclib. Thank you.
Thank you so much, sir, for your excellent talk. And we'll move for the panel discussion on the discussed abstract. For this, I would like to invite moderator Dr. Sajjan Rajpurohit, sir. Sir is Senior Consultant Senior Director Medical Oncology, BLK Max Hospital, Delhi. And we have only 3 panelists available. So Dr. Abhishek Sharma sir from Jodhpur, Dr. Shefali Sadhana ma'am from Delhi, and Dr. Abhinav Navaria sir from Delhi. Over to you, Sajjan sir.
Am I audible?
Yes, sir. Yes, sir.
Okay. Thank you, Dr. Aki Chaudhary, for inviting me for this evening symposium. So, we have 3 panelists and we have 4 trials. So what I'll do is I'll start from the first one is the surgical trial, how the surgical landscape is changing. So So I have Abhishek, Shifali, and the third person is Abhinav. Okay. Okay. Abhishek, to start with you, what is your take on the impact of enzema? Will that change your colleagues' practice? So, when you're working as a multidisciplinary team, sometimes your colleagues might be keen to go for um, axillary lymph node dissection or sentinel lymph node dissection. So, what is your take on whether if a patient is got a early breast cancer disease and clinically and by ultrasound the nodes are negative? So, are you convinced to help or tell your colleague who is a surgical oncologist that they can actually avoid sentinel node biopsy? So, that's my question to you, first of all.
Yeah, sir.
Abhishek,
Yeah.
Abhishek, can you
Hello.
hear me? Did you hear the question? Abhishek, could you
Hello.
hear the question? Hello, Abhishek.
You.
So, am I audible? Am I audible to all of you? I don't know. Whether I'm audible or not. Abhishek, am I audible to you? Uh,
Hello.
okay. Meanwhile, I think Shifali, could you hear me? I don't know whether I
Dr.
audio audible.
Sajjan, you are
Yeah.
audible. There
You are
might be a
audible.
network issue
Yeah.
on Dr. Abhishek's side.
Okay, Shifali, I guess you heard that question. So
Yeah.
the question is it is this data convincing enough for your surgical colleagues to omit sentinel node biopsy in early breast cancer clinically node negative patient? That's my question.
Yeah. So, see, I mean, obviously in breast, we are talking about the de-escalation kind of thing. Maybe it is medical treatment, maybe it is surgical. Of course, we know in SEMA, there were 5,000 patients, data is impressive. But whether we can extrapolate in our setting is a difficult question. So, I mean, practically right now, we are still following early node negative, doing the sentinel node. But of course, the results are impressive. It should be followed. It should be, we should start practicing it. That is
So
how.
you feel it definitely is a positive, impactful study, and if somebody of your colleague would like to make it as a part of clinical practice, they might not be wrong because they have some data which is quite robust with a large number of patients. So
Absolutely,
Abhinav,
absolutely.
what is your take on the data from NCMA, and will that really impact practice for your surgical colleagues tomorrow morning?
Sir, I have discussed this data with many of my surgical oncology colleagues, but they are still not very convinced, even though there is a data of 5,000 women, but still many of them do not agree to, put this into their practice. They still want to, go ahead with the axillary dissection. So that is my take, because this is, at the end of the day, I can just say them that you should follow this, or we can think in a multidisciplinary tumor board, but still they don't look very convinced with this.
Yeah, actually, the thing is that the population in our setup is little different from the Western data. So we have younger population, little, I mean, aggressive risk factors to be considered. That is why they may not be comfortable. We agree on that.
Yeah,
But
yeah.
data is really impressive. If we start doing it in, say, a favorable subset of the patients and see the results, I think that will give us a better insight into.
Yeah. So I think you both have made valid points. So in a, I think more carefully selected case,
Yeah.
it might be applicable. And if today a surgeon decides to not make that patient undergo sentinel node biopsy or sentinel lymph node dissection, it could be one of the possibilities. So I now come to Abhishek. Abhishek, are you there? Can you hear me?
Yeah, sir. It's about eczema. I want to talk about that, sir. When we discuss this, our surgical oncologists, they are not. I am convinced with Dr. Abhinav. They are not convinced with the data. According to them, it should be chosen in a specific population. Then we can plan. Otherwise, they are not convinced with this eczema data. But that data is quite impactful. I think we should include surgical oncologists when we discuss about this eczema trial. So it should be included. But right now, most of surgeons is not practicing eczema.
Yeah, I think you all made valid points. Now I'll come to the second study, which is Supremo MRC, again, a de-escalation study. And in fact, most of us, when we started our careers only N2. So the standard guidelines for radiation were actually T3 versus N2. That's what was being a part of NCCN. And N1 was not really a part of RT, especially if there was a MRM which was done. And later on, we found that N1 was incorporated. So now coming back to the same question again. So I will start with Shifali first. Shifali, what is your take on this de-escalation strategy where they have tried to make either T3 N0 or T1 T2 N1 where they want to avoid radiation. So what is the impact of this study? How you feel about this study?
So
Shifali.
again, in say selected 2, 3 patients, we have offered that not because of by choice that we want to de-escalate, because again the radiation oncologists are not fully convinced, but of course patient did not wanted to have it, so we have that data backup. Okay, if you do not want it, if you are reluctant, if we have comorbidities in that concern, we have now data backup to say okay, we are not losing much on that ground. So we have offered it in 2 or 3 patients, but not by choice actually.
Okay. So Abhinav, do you feel there's a subset of patients who might actually be good candidates for this data, or it can be now offered to all comers?
So generally, node negative patients who have undergone mastectomy, I do advise not to, for chest wall
No, no, no. So
No,
I
it is
just
node
no.
positive,
So
N1.
So, okay, so
And
it is for patient, okay, it is for the patients who are either T1, T2, N1 or T3, N0. Because,
Yeah,
the previous guidelines were that any patient who has at least got T3 or N2
yeah,
were were given radiation in the adjuvant setting. And then there was a clause which was added in NCCN over the last 10 years where I found that even N1 was incorporated into adding radiation. Now, with this data, which is again a long data, 10 years data, where
yeah.
it is found that probably in T1, T2, N1 or T3, N0, radiation does not add to any um, distant disease-free survival and also has comparable local recurrences. So does
Outcomes,
not affect the
yes.
yeah. So this is the data which has come from Supremo MRC. It's a 10-year data. Again, a big subset of large number of patients. So what is your take? Like, you have some comment to make on this?
yes, sir. So basically, it is all about choosing the patient. If T1, T2, N1 or T3, N0. If patient is a young patient, you want disease control. So it is all about personalizing your treatment options.
Okay. Okay. So, Abhishek, what is your take on Supremo MRC? For all the patients you can offer, or now this those data is robust enough to be a part of our clinical practice? So again, because we all are medical oncologists, unfortunately, I don't have anyone in the panel here or somebody who's in the audience who's a radiation oncologist. If they would like to unmute yourself and answer this once Abhishek has responded. So Abhishek, your take on this data? I think Abhishek has some network issues. So, okay, I'll move on. So my take will be that yes, this is quite convincing that these patients might not really have an additional benefit in the disease. And obviously, we
Hmm.
all understand that post MRM patients actually, when they are exposed to radiation, they have highly likelihood of post RT changes and having higher chance of
Absolutely.
live. Yeah. So this could be really thought-provoking, especially for our tumor board meetings, and probably we could actually convince some of our radiation oncology colleagues, especially for like one node positive,
Yeah,
that this could be, and if the disease is favorable and the patient is elderly. So I think those are the areas where we could actually tell them that this could be omitted. Again, it will depend upon how they adopt this to this data. Now I'll go to the next, which is the Natali study. So Abhinav, I will start with you. Abhinav, what is like? How convinced are you with Natali data number one? And yeah, after presenting this data, because we have two type of patients. There is one area where, in fact, Natali has gone even to node negative high risk. They have defined a high risk population, whereas Monarchy is into absolutely, I think, node positive and high risk. So
yeah.
first, number one question is, how would you choose your CDK4/6 inhibitor? Are you convinced enough that probably ribociclib is better than Abima in the adjuvant setting. So first, if a patient comes to you tomorrow morning, which data is more convincing to you? Number one, because the number of years also you have to have one additional year of ribociclib. So that also. So based upon both the studies, what is your take upon whether you'll go for monarchy or Natali?
Sir, in our current practice, we are all convinced with monarchy trial, and we all are giving adjuvant abemaciclib only. So even if we see Natalie data is not that impressive. So in my routine practice, I am using abemaciclib only. But yes, if any patient is intolerant to abemaciclib, then we can think of ribo.
So I think Novartis will have to make you more a presenter for them to convince you enough. I hope that if they are here and they should convince you. Shifali, what is your
Yeah.
take? Is it the same or is
So
it different?
I think Natali covers a broad spectrum rather than Abimax. I mean, clearly. So I think 1B onwards included patients with a high risk, maybe Ki-67 of a higher value or an Oncotype DX score of more than 26, where we know that, okay, endocrine therapy is not going to give you that spectrum of benefit. So you need add-on therapy. So I think I'm pretty convinced with Natalie data. And to me, ribociclib 400 mg is pretty much well tolerable than Abima. So my practice is obviously both options, but I prefer personally ribociclib over Abima because of the toxicity profile. Though I understand that it is 3 years versus 2 years, it is sometimes difficult to convince the patients. But of course, tolerance wise and the broad spectrum coverage, I think Natali suits better.
Okay, so I have two
Yeah.
medical oncologists who have different choices, but again, yes, the best thing is that we have choices. So
Yeah.
obviously, any of them would be better than not using any of them. So
Yeah.
I think that's the way forward. And obviously, with more time and more data, we'll be more wiser to choose among both of them. So now I'll come to Olympia. So Olympia, so again, Abhishek, Abhishek, are you there? Because if you're there, if you could answer that question. Organizers have not been able to reach Jodhpur with their data, and I think there's some issue with the network in Jodhpur. So I hope that I'm not left with only one panelist by the end of my this thing. So good that you both are in Delhi. So Shifali, your take on Olympia? How do you perceive this, and which are the patients which you will consider Olympia?
Yeah, of course, I definitely practice Olympia in patients who have a residual disease post NSCT in a triple negative setting or a node positive in a hormone receptor where ERG score matters. And we know that in germline BRCA mutated patients, these are the high risk patient and have a poor prognosis as compared to the non BRCA mutated subset. So I think I would be happy to use Olympia, and I'm currently practicing also of this olaparib for 1 year post adjuvant therapy. Yeah.
Okay, okay. Just to check with Dr. R.K. Chaudhary also there with us. Dr. R.K., if you could just answer this question for us. Uh, what is your take on patina? So are you convinced about the data because it looks very impressive? So what is your take for adding palbo, and probably sometime later we'll have data with ribo? What, I don't know. They could be really fascinating data, especially with patients who are HER2 positive, because logically it appears that yeah, if we are continuing them on HER2 dietary therapy, we should also continue them on the best of hormone dietary therapy. So what is your take on patina?
I think you rightly mentioned the data are sufficient enough to convince, I think.
Yeah, so couple of things in my mind regarding patina actually. So if
Yeah.
we see the control and experimental arm, I think CRPR was 70%. And in PR or a stable disease, I mean, we are practicing Catherine now. So will it make a difference? I mean, I don't know whether trastuzumab, pertuzumab plus palbociclib and the endocrine therapy versus TDM1 and other things. Will it make a difference? Number one, I don't know in this setting. So that was the thought process in my mind, how to go about it. And are we using it in every patient? So maybe I mean or a select group of patients. That is also again a thing. So how
Yeah,
do you
I
take
think
Dr. Sajan? Yeah.
So yeah, I actually agree with you because difficult to actually have these two inhibitors, but probably
Mm,
later in line because now we have more effective drugs for
yeah,
HER2-directed therapy.
correct.
But then this subset where it is actually triple
Wait, wait,
positive.
Saurabh.
Mm,
Triple positive is actually a
yeah.
bad disease to really have. So I don't know how this will be taken up, but then at least I would say that if you are going only for one HER2-directed therapy and not
Mm,
like have drugs like TDM1 or probably NHER2, then in those
mm,
settings we might have
yeah,
incorporation of this into. So there might be still some patients, especially who are not very affordable, and there is where
yeah.
probably we might have this as a alternative option for our patients.
And
So
do we have
till
a
now,
breakup that okay in CR subgroup how much was the benefit versus in the PR or stable disease? Stable disease I understand that they do really bad because they the response is not that great. But in a CR
yes.
group of patient, I'm not sure what kind of benefit it gave additionally.
So I think Rajat had presented this data, and if
Mm.
I were to see this in the subset, which was okay,
5 मिनट 5 मिनट
नहीं जल्दी भी भेज सकते थे वैसे बात नहीं.
3 मिनट
So I'll have to look into this.
Sure.
Okay,
I
I will
was
look.
also not aware of. No problem.
Does the
Sure.
case
ठीक है.
Abhinav actually become very
5
busy after becoming independent. So I understand. To,
so
to
sorry
increase
the
your
right
practice, you have to always be on go. So Abhinav,
yes sir
so before you leave us, and I won't take you like more than 2 minutes. This is the
yes
last answer which you have to give. Then we are closing our session. What is your take on patina data?
Sir, so it is very difficult you in a metastatic setting where you don't know whether it is HER2 is the driver or hormone positive. So wherever my patients are not able to afford a dual anti-HER2 therapy, or maybe they just want to go with trastuzumab. So adding palbociclib after there are so many brands of palbociclib which are cheap. So we need to add something, so I am convinced with it. And while I was working with you, also we started off-label use sometimes when we were confused at what to do next, and when patient was financially challenged, we used to do it, and we have seen results on our own also.
Yeah. So I think there's a subset which could benefit. Shivali, you want to add something?
Hey, nothing. I was little confused earlier that it is in the adjuvant setting. So Catherine though is in
No,
adjuvant
it is
setting.
metastatic.
Yeah,
Metastatic.
it is
Metastatic
metastatic.
setting. Very
But
I
good.
but
realize.
but but your point is well taken.
Absolutely.
Even in metastatic setting, you might have antibody drug conjugates, and there it might not be
Yes,
a very good thing
TDXD
to
and
do. But
all.
yes, yeah. But
Agreed. Agreed. Sure.
so with this, I like to really thank all three of my panelists and Dr. RK, and back to the organizers.
Thank
Thank
you
you so
so
much.
much.
So thank you.
Th-
Thank you. Okay.
Thank you so much, sir, for the excellent panel discussion. So we have net talk by Dr. Sajjan Roy, sir. We have already have, and sir will talk on a flexible future transforming the paradigm of HER2 positive breast cancer treatment. And this session is sponsored by Roche. Over to you, sir.
Okay, if you could, yeah, presentation. So I would like to thank again Dr. Akit Chaudhary for actively involving me into his academic meeting here. So without wasting much time, I like to start this next presentation, which is impact of subcutaneous dual HER2 blockage on patients of HER2 positive breast cancer patient. Please change the slide. So it is very important because this has been such a important addition to our next slide, please. Next slide, because the patients have been treated for 1 year with anti-HER2 therapy, and sometimes a better drug delivery system can make a lot of difference in their quality of life. So, achieving a pathology complete response with neoadjuvant chemotherapy resulted in longer survival in patient than patients who had residual disease. And this we now know that pathological complete responses are a surrogate marker of OS. Next slide. And it has also been now found that if we add dual HER2 blockage compared to only trastuzumab, and we have now robust data from various trials which have found that the complete response rates are much higher when we use uh, pH versus only H to the therapy. Next slide. Again, if we have dual HER2 blockage in the neoadjuvant setting, the EFS is much higher compared to this. And if this has been seen in the various trials, including the Neosphere and Trafina and Christine, where if we just compare the difference between, if you just see H versus pH, the difference was quite statistically significant and clinically meaningful in all these studies. Next slide. And this has been also published by Sandra Swain et al. Also, that EFS in patients with early HER2 positive patients with a pathological complete response after HER2 therapy with a pool analysis of all these trials. Next slide. And the pool analysis showed that patients who had um, so if you just see here, the number of events were almost one fourth. So if you just see H followed by H versus PH followed by H, the event-free survival was number of events were only 79 in the PH arm versus 217, and the hazard ratio in favor of this was 0.56. So this was almost a half decrease in the events. Next slide. And also shows that the cardiac safety actually was similar in both the cohorts, and the addition of pertuzumab to trastuzumab did not add to any incremental toxicity in the cardiac risk of the patient. Next slide. And also the phase 3 Peony and the Peony trial also showed that efficacy, safety, and tolerability of pH with docetaxel for patients with early or locally advanced patients was actually efficacy was better, and safety and efficacy, the safety and tolerability were equivalent. So most common adverse events in more than 30% of patients was diarrhea, and actually was more common. So diarrhea was actually around 40.8% patients versus 17.3% patients in the only trastuzumab arm. But EFS, DFS, and OS, all the data was actually supportive of total pathologic complete response and such as a clinical meaningful improvement with PH versus H only happened before surgery in all these patients. Next slide. Current status of dual HER2 blockage. Next slide. So if you just see here in the latest NCCN guidelines, so patients who have been on preoperative or adjuvant therapy, TCHP is one of the preferred regimen in these patients, which is a regimen which has no anthracycline and a dual HER2 blockage. And if there is no residual disease after preoperative therapy, then the patient has to be continued on trastuzumab plus pertuzumab. And if there is a residual disease, then we actually escalate the treatment to having TDM1. Next slide. And this shows that patients who have been treated with surgery, patients who are node positive also, dual HER2 blockage is better than only giving trastuzumab. Next slide. Next slide. So even in patients who are metastatic, the dual HER2 blockage in the form of trastuzumab, pertuzumab, along with a taxane, either docetaxel or paclitaxel, is preferred regimen. So in all the settings of neoadjuvant, adjuvant, and metastatic setting, a dual HER2 blockage with pertuzumab plus trastuzumab is better than only single agent trastuzumab. Next slide. And if you just see the ESMO guidelines also, patients who have got a disease which is which is node positive, again, it has been recommended to go for dual HER2 blockade in the form of HP, and patients who have got more than T2 size also, if they have been exposed T2 or node positive who have been exposed to TCHP, and after surgery pathological complete response, then complete 1 year of trastuzumab. Um, and if they were clinically node positive at the initial diagnosis, then add pertuzumab also. And if the patient had residual disease, then complete 14 cycles of TDM1. Next slide. Now coming to the IV therapy, because this has to be continued for 1 year, and that definitely makes it very cumbersome for patients, because logistical and time burden for attending appointments, physical pain and discomfort, infusion administration, support of family and friends, emotional, all these have a negative impact upon the patient. Next slide. So nature of burden faced by patients, obviously this is the because the more they are into infusion journey and they keep coming every 3 weeks to the chemotherapy ward for 1 year, it actually leads to um, a kind of a difficult time for them, and their own life circumstances can also make it sometimes difficult for them to comply. And then they require financial support, emotional support, all doing before and after treatment. Next slide. And again, lengthy time of appointments and pre-planning is required for majority of logistic burdens to have IV infusion for patients. And IV infusion duration is only one aspect of the patient's appointment day. And in fact, they end up spending almost the whole day for IV therapy. Next slide. So this actually could have a negative impact upon the emotions of breast cancer patients in the form of anxiety, frustration, guilt, and isolation. Next slide. In studies done to assess the impact of depression, anxiety on survival, depression was associated with the cancer recurrence, all-cause mortality, and cancer-specific mortality, and morbidity of depression, anxiety is associated with all-cause mortality and cancer-specific mortality. Obviously, when somebody is into a continuous IV treatment, they tend to feel low, and they actually could go off the treatments once they feel that the surgery has been done and they're doing absolutely fine, and that they tend to associate IV therapy with continuing treatment. And again, obviously, IV infusions of both the drugs, they have long infusion observation and congestion at clinics and hospital. They have high resource burdens, and then indwelling catheters have to be kept, and which could lead to infections and other complications. And venous access can also be sometimes a challenge for many of the patients who could be obese or elderly. And all these are unique challenges in each patient. Next slide. Phesgo is the first formulation oncology to combine two monoclonal antibodies, pertuzumab and trastuzumab, into one vial for subcutaneous injection. Contains the same antibodies as approved by Perjeta, IV Perjeta and Herceptin, but has got different route of administration. It is formulated with the recombinant human pertuzumab, and which is a recombinant human hyaluronidase, to allow subcutaneous injection of higher drug volume, 15 ml loading dose and 10 ml maintenance dose. And it is a ready to use fixed drug combination administered by subcutaneous injection in the thigh over approximately 5 to 8 minutes. So compared to infusion time of both the drugs extend to 4 to 5 hours, this actually gets over by 5 to 8 minutes and around half an hour of pre-medication. Next slide. And again, the trials have shown, this is Federica as well as Francisca trials, which have shown that there's a non-inferiority at cycle 7, and and pre-dose 7 of in the terms of the pharmacokinetics, where actually the Phesgo was in fact higher in terms of the C trough levels of the drugs for both the drugs, and pathological complete response was almost identical between the arms, and Phesgo was well tolerable with safety data that was comparable to those used in the IV PH combinations. And in the Ferenczka study also, 85% of patients had preferred Phesgo over the IV infusion. Majority of SCPs felt that switching from P plus H IV infusion to Phesgo actually save time and resources and doing the drug preparation and treatment. The safety profile of Phesgo was consistent with previous studies, and no new safety concerns were observed, including switching from IV to subcutaneous. And in fact, in my own practice, also, I found that almost everybody I've given the drug, except for barring like 1 to 2% patients who had some subcutaneous inflammation, which also settled with cold packing and gentle massage and some anti-inflammatory drugs. None of the patients surprisingly had any major local reaction. That has been really surprising, because even I thought when we will infuse around 15 ml of fluid or 10 ml of fluid, it will be difficult to infuse. But then most patients absolutely have no pain. It just goes so smooth, no swelling, no induration, nothing happens to these patients, and which is, I think, a very remarkable kind of a drug for them, because it becomes the whole process becomes very easy for them. And long term also efficacy data remains immature, but then if we just see the higher 3-year DFS and OS rates have been seen. So it appears to be relatively superior, though we don't have much more long-term data. Next slide. Okay. Two innovator molecules in one single dual shot, and both have shown non-inferiority and with pathological rates being comparable, being well tolerable, and no new safety data being observed. And long term also, they show that 3-year IDFS as well as OSR were relatively higher. So it's good. Next slide. And this is one innovation which prioritizes patients' safety. And if you talk about side effects, diarrhea is the most important side effects. And in fact, more patients in the IV arm experience diarrhea compared to the subcutaneous arm. But still, in both the settings, they had diarrhea as one of the most important side effects. Next slide. So if we just see all the adverse events, whether it is emergency, serious side effects, cardiac dysfunction, LVF decline, or withdrawal of anti-HER2 therapy, both the agents were almost well matched to each other, and a little in favor of Phesgo compared to IV PNH. Next slide. 93 of the patients who actually preferred Phesgo and had a very strong or a fairly strong preference for Phesgo compared to the IV infusion. The main reason for preferring subcutaneous administration required less time in the clinic and feels more comfortable doing administration were consistent with the previous data. Next slide. Again, majority of healthcare providers also felt that switching from IV to oral would save time and resources, and also doing preparation and treatment. And the perception actually was favor of Phesgo compared to IV infusional pertuzumab and trastuzumab. Next slide. 66% of patients found that they did not require cannulation, and without cannulation, they were more happy, or they didn't require indwelling catheters like chemoport or PICC line. And this actually helped them with the quality of life. Next slide. Again, the assessment of cost effectiveness of HER2-directed therapy pathways in neoadjuvant treatment of high-risk HER2-positive early breast cancer. A hybrid decision-free Markov model was done to simulate the cost and outcomes across 6 health states. And neoadjuvant targeted therapy, IV versus subcutaneous uh, versus trastuzumab alone, and adjuvant therapy also, and then adjuvant targeted therapy and use of brands or biosimilars was placed into this. Next slide. And compared to the all other combination, the fixed dose combination in the subcutaneous form was actually better and more cost effective compared to the IV version. Next slide. So to conclude, neoadjuvant breast cancer treatment with fixed drug, the combination of pertuzumab and trastuzumab, followed by adjuvant continuation in transition to TDM1 in case of um, residual disease, or continuation of the FESGO, if there's a pathology complete response, is a cost-effective strategy for patients with high risk HER2 positive early breast cancer. Adjuvant treatment continuation with FESGO does not contain so actually dominates all the strategies that do not contain pertuzumab, as well as in where IV pertuzumab therapy is continued. While it is costlier than strategies which have IV pertuzumab therapy is discontinued after achieving pathology complete, these additional costs are generally low relative to the clinical benefit obtained. So if we see all the scenarios, the fixed drug combination, the subcutaneous route is better than the IV route. Next slide. So free from lines, free from pain, free from difficulty. And I think this is what has made FESGO as a preferred route of administration of dual HER2 blockage. And in fact, this has led to most clinicians adopting to this in their clinical practice. Thank you so much.
Thank you so much, sir, for your talk. We'll move forward for the next talk. And for the next talk, we have Dr. Vinay Bhatia, Head Molecular Biology and Genomics, Onquest Laboratory. And we'll talk on Mama Print and Blueprint. So over to you.
Good evening, everyone. So I'll just share my slides. So good evening, everyone. I'll be talking on clinical application of gene expression profiling with Mama Print and Blueprint for early stage breast cancer. So in this presentation, I'll be talking about what are the different trials which were conducted for chemotherapy planning and to back the decision on chemotherapy planning and endocrine therapy planning with respect to these two testing modalities. So just to begin with the introductory slides, Mama Print is nothing but a 70 gene microRNA based assay, and it has a potential for distant metastasis. So you can see in this slide there are different pathways which are involved for the process of metastasis, and there are almost 70 genes which are responsible for this pathway. So in this particular panel, the 70 genes have been included, and which will help us in finding whether if the basing on the expression of these genes, whether a particular breast cancer in a patient has a potential for distant metastasis. So result of this particular test is being given as either low risk or high risk, basing on the MPI score or MPI index, which we call as Mama Print index. So the next is 80 gene blueprint assay. Just like the traditional pathology where we designate a tumor into HER2 positive, ER/PR positive or triple negative breast cancer, this particular test is based on again microarray, on RNA-based microRNA, which will target signaling pathways which are driving tumor growth. And again, basing on this expression of these 80 genes, a tumor would be molecularly subtyped into either luminal type or HER2 type or basal type. In short, blueprint, the 80 gene molecular subtyping assay, goes beyond the surface to evaluate the underlying biology of a tumor and what is driving its growth. So this is a reporting format of Mama Print and Blueprint, where in Mama Print we have two findings, either low risk or high risk. Low risk is further subdivided into either low risk or ultra low. So if the MPI score, which is Mama Print index, is between 0 to 1, it can be low risk. But if it is further subcategorized into low risk and ultra low risk, basing on the value, if it is 0.001 to 0.355, or ultra, it would be ultra low if it is between 0.356 to 1. Similarly, for high risk category also, they have subgrouped this category into high risk 1 or high risk 2, depending upon the score. If it is between 0 to minus 0.569, then it is high risk 1. And if it is beyond 0.57 till minus 1, it is high risk 2. So, and blueprint is further subcategorized either as luminal type, HER2 type, or basal type. And if the report is a patient test has been asked both for mama print as well as blueprint, then the further combined report would be generated as mentioned in the lower part of the slide, where either it could be low risk luminal type A, ultra low risk luminal type A, or high risk 1 luminal type B, so on and so forth. So moving further, what does this mama print assay tells us? So there was a query whether which particular breast tumor can metastasize early. So this query is being answered by this particular development of this particular assay, which is nothing but expression of 70 gene, which will actually help us whether there is a chance to a patient would have a chance to metastasize or not, based on the risk index which is being generated. So the first trial which was conducted to support this data was MINDEC trial, where more than 7,000 patients were enrolled. And the first data was came out in the year 2016, where 60% of follow-up patient at 5 years survival with 5 years outcome were presented, followed by in 2020, where median follow-up of 8.7 years was given, where 5-year and 8-year outcome were presented. So here we can say if the group of patients which were clinically high, means their tumor size was high, then it was node positive, or maybe a tumor size is that high, parallelly clinically high risk category. But when those patients were selected with mainly ER positive, HER2 negative cases were selected, and those patients were just given ET, not chemotherapy was not given. So when the distant metastasis free survival for women with clinically high, but these patients were mama print low risk when the mama print was done. So those patients were, this cohort was put on ET alone, and 5 years, 5-year distant metastasis-free survival was monitored, and it was observed that when the patient showed 95.1% of distant metastasis-free survival. So the clinically high risk or mama patient, which were mama print low risk, when they were put only on endocrine, it was clearly indicated that mama print low risk may avoid chemotherapy regardless of the clinical risk. The second endpoint of the trial was the patient cohort was divided into two different categories. One arm was chemotherapy, the other given chemotherapy, and other arm was without chemotherapy. So chemotherapy arm is represented as red color, and no chemotherapy is as blue color. So we can see that absolute difference in DMFS between CT arm and no CT arm at 5 years of interval was just negligible. This was just 0.9%. But when for another 3 years, when total 8 years after it was examined, that there was a difference of only 2.6%, as evident here in this particular representation. So this cohort was further divided and subcategorized into age wise. 50 years of patients who are below 50 years of age were given were examined as compared to postmenopausal patient above 50 years of age. So again, this data shows that for patients who were postmenopausal, there was not much difference in distant metastasis-free survival when patient was given chemotherapy or were not given chemotherapy. While in case of premenopausal patient, there was a difference, but that difference was evident after only 5% of difference was observed after 5 years of trial. So what can be the reason behind this? So it has been presented in different research articles also to justify this, that it is possible that this age dependent effect is due to chemotherapy induced ovarian function suppression. So this was the model they had presented, that if a postmenopausal or premenopausal patient with the clinical high risk and mama print is low, is mama print is high, then CT should be given. But if it is mama print low in case of postmenopausal, then there's no need for CT. While in case of mama print low, in case of premenopausal, the scenario can be discussed with the patient about the risk and benefit of chemotherapy, and the factors like ovarian suppression, function suppression, and CT impact can be discussed. Similarly, another cohort was taken where patients were ER positive, HER2 negative, along with node positive. And again, the comparison was made with CT arm and no CT arm. And again, there was not much difference at 5 years of distant metastasis-free survival ratio, while at 8 years, it was just a 1.3% difference. So again, that was the chemotherapy related planning, which basing on mama print result. Now moving on to the cohort which is called ultra low cohort. So we had already discussed that mama print low risk index is between the range of 0 to +1 with no chemotherapy benefit, and there is a group which is ultra low risk index with ultra low index between 0.355 to 1, which shows excellent prognosis at over 10 years. So there was another trial, Stockholm tamoxifen study was performed on 652 postmenopausal women with the tumor up to 3 centimeters of size and low lymph node negative, clinically low risk patients were taken into this trial. Out of 652 women, 339 randomized to no endocrine therapy and 313 randomized to tamoxifen for 2 years. Out of 313 patients, 65 were given tamoxifen for 3 years, and 35% patients were given the same for 5 years. So out of this population, 19% patients were ultra low risk cohort, and the 20-year follow of ultra low risk cohort for with any endocrine therapy was showing that there is a 97% of breast cancer specific survival at 20 years, and it was 100% for 10 years. Similarly, it was 94% for with no endocrine therapy and 100% for 10 years. So this is another way of representing the same data which I have discussed now. Mama print ultra low risk postmenopausal with show excellent outcome with little or no endocrine therapy. So postmenopausal women with ultra-low breast cancer may not require 5 years of endocrine therapy. And as per this mandate and Stockholm's tamoxifen trial, and there can be even discontinued therapy if they are experiencing significant toxicity as per this trial. So the additional studies were performed similar to this in 2 different additional trials. One was IK trial, the other one was focus trial, and the findings were on the similar lines. This particular mama print ultra low has been included in NCCN guidelines on breast cancer in February 2023. ESCO also recommends mama print as the only test of its kind recommended to inform treatment decision for lymph node positive and lymph node negative breast cancer patients. So moving to the benefit of mama print, clinical utility of mama print for extended and endocrine therapy. So this was a trial which was done as the name of the trial is NSABP B42 trial to justify the same, to conclude the same. So here, mama print low risk, not the ultra low risk patient, was shown to get benefited with extended endocrine therapy as evident from this representation. The mama print low risk patient showed 95% more absolute benefit in 10 years distance disease free survival as compared to if you compare MP ultra low risk or MP high risk patient. So in short, this is the clinical utility of mama print. It helps in chemotherapy planning based on the mama print index. Parallelly, endocrine therapy planning in an ultra low risk patient. Also, the utility is also in clinical utility is also in providing information about extended endocrine therapy planning for low risk patient, not the ultra low risk patient.
Ma'am, sorry for intervening. Need to conclude, please.
Yeah. So this is flex study, which also supported the same. So I quickly move to the blueprint. Blueprint I had already mentioned. We have taken 80 different genes. These are the genes for which are the luminal type signature for 58 genes in luminal type, and for HER2 we have 4 genes, and for basal type there are 28 genes. So this was a trial which was conducted where neoadjuvant therapy based on ISC and FISH was given and compared with genomic profiling, where genomic profiling showed discordance with ISC and FISH based assay, that 22% patient was showing different findings as compared to traditional genotype, traditional typing method, which are ISC and FISH as compared to genomic profiling by blueprint. And it has been seen there is a difference in pathological complete response with respect to ISC-based assay versus blueprint versus assay, as evident from this slide. So if it is ISC-based assay, then PCR is only 10%, but for blueprint, we have further categorization as luminal A, B, HER2 or basal. And so ER positive cases show more than 34% of PCR. So clearly indicated that if basal type blueprint is basal type, then neoadjuvant therapy is being recommended. So this is the result of the finding that clinically ER positive HER2 response to neoadjuvant therapy is more in basal type as compared to the rest of the other types. So this is a biology which I can skip. Biology of ER positive basal breast cancer. I'm skipping this. So 5-year outcome in NBREST trial is preoperative mama print and blueprint breast cancer subtype is associated with neoadjuvant treatment response and survival. So this is the blueprint trial which we had discussed just now, and breast trial, and the response of NACT response in high risk hormone positive basal subtypes in long term, and it's a long term outcome. The similar findings were reconfirmed by I-SPY2 trial. And this is quite evident that MP high 1 and high 2 predicts increasing chemosensitivity. And as reflected by a flex trial also. So in short, this mama print and blueprint has a additional advantage that as compared to other genomic profiling tests for breast cancer, where this test is FDA approved. This is studied in clinically high risk patients. It is validated in untreated patient. It provides information about the tumor subtyping along with the risk of metastasis in the patient. So this is a provisional algorithm which has been given by Age India pertaining to different findings which we get on blueprint and mama print. If it is luminal A ultra low, then surgery or neoadjuvant endocrine therapy, and for basal high risk, it is neoadjuvant chemotherapy. If it is because there is high likelihood of PCR in such patients, which are equivalent to triple negative breast cancer patient. So this is a comparative of all the genomic profile assays available, like Oncotype TS, EndoPredict and all. This is the only assay which has taken patient population which are ER positive negative, HER2 positive negative, and node negative positive both. And this in addition to that, it provides BP blueprint, which is applicable on all early stage breast cancer patient. This is approved by ASCO and NCCN. So, and it is prognostic as well as predictive assay. So this is a simple report format which I would like to mention. So I think.
Ma'am, great presentation, but we are running short of time. If you can conclude, please.
I end here. Yeah, I understand. So I end here. This is a reporting format which will give you the everything in a first page, which will be giving apart from the risk, neoadjuvant chemotherapy planning, adjuvant chemotherapy planning, adjuvant endocrine therapy planning, along with the score basing on the clinical trials and data which I have shown you just now. Thank you so much for your patience.
Thank you so much, ma'am, for your excellent talk. We'll move further. We have a next session on gynecological cancer.
Yeah.
And we have a panel discussion. Panel discussion topic is management of recurrent and epithelial ovarian cancer. And for this, we have a moderator, Dr. Abhishek Raj sir. Sir is senior consultant and unit head medical oncology, Sarvodaya Hospital, Faridabad. And for the panel discussion, we have only 4 panelists available. Dr. Rahul Modi sir, and Dr. Piyush Bajpayee sir, Dr. Keshav Garg sir, and Dr. Abhijit sir. Over to you, Abhishek sir. Thank you. Sir, you need to unmute yourself.
Hi, good evening. Good evening. Thank you for the kind introduction, and thank you, Chaudhary sir, for inviting me for this. And do we have all the panelists here? I can see Piyush Bajpayee sir. How are you, sir? Hi, good evening.
Hi,
Sir,
good evening, Dr. Abhishek.
sir, we have 4 panelists: Dr. Rahul Modi sir, Dr. Piyush Bajpayee sir, Dr. Keshav Garg sir, and Dr. Abhijit sir.
Okay, okay. All of them have joined. Okay.
Yes, sir.
Yeah. So I have been given this task to moderate this panel discussion on recurrent ovarian cancer. I think majority of us we do face a lot of challenges in managing this case on ovarian cancer. So quickly coming on to the case. So this is a patient that we are discussing. So it's a 60-year-old female. No significant comorbidity. In November 2022, presented with abdominal distension, bloating, evaluated outside with a CA-125 of 1000. Workup was suggestive of pelvic ultrasound, where ovarian masses were seen on both sides. And it was similar kind of a picture on a pelvic MRI with peritoneal carcinomatosis ascites. And she was biopsied, and histologically she was WT1 positive, P53 mutant. So she was diagnosed as a high-grade serous ovarian cancer, treated with 3 cycles of neoadjuvant chemotherapy, good partial response. She underwent initial cytoreduction. And in April 2021 to June, she received the further 3 more cycles of chemo. And in July 2022, like almost 13 months later, she relapsed with a 5 centimeter pelvic mass and a 2 centimeter subcapsular deposit. So my question to Dr. Rahul, so what will you do in such a case, sir? If this patient has come to you, you have, assuming that you have performed the primary surgery, is following up with you, what will you do here?
Yeah. Good evening, Dr. Abhishek. So, as a surgeon, I think first we look at the basic parameters, looking at the fitness of the patient. And as I can see, the platinum-free interval is crossing more than a year approximately. So, follows the platinum-sensitive group. So indirectly fits into whether I can do surgery or not. So world over, there are multiple systems on which we take a decision. So there are mainly 3 trials, like the desktop trial, which gives a score, which is called as the AGO score. There is a Chinese trial, which is a SOC1, which gives a eye model score. And third was the GOG 213, which was at the surgeon's discretion. So even for us, I think according to all, even if I look at the AGO as well as the surgeon discretion, we can go for a secondary cytoreductive surgery in this case, considering there is recurrence at 2 sites. So it is a kind of a oligometastatic recurrence. So a secondary cytoreductive surgery having a CC0 resection again at the secondary CRS will give her much benefit in this setting.
Okay. Piyush, sir, your opinion, please. Would you like to incorporate a tumor board discussion, give systemic therapy first, or involve the surgeon first? Anything else you would want to do, sir?
I think so. If the good performance status is there, no ascites, as you mentioned,
I can't hear you, sir.
Separate. Am I audible?
You are audible now, sir. I'm not sure if it's a problem at my end or yours. I can't hear you. I can't hear you.
So
somebody from the organizers, are they able to hear Dr. Piyush, or is it problem at my end?
No, sir, it's Piyush Bajpayee's bandwidth is very low. That's why.
Oh, okay. I think so. Dr. Piyush, try again, sir, please.
I'll just join again.
Okay. Meanwhile, let me take
I'll
this
just
up.
join again.
Okay, so let me take this up with Dr. Keshav. Dr. Keshav, what is your opinion, please? Here, would
Okay.
you discuss and
Hello.
would you be more keen with the surgery? Yeah. Hi. Good evening.
Hello. Good evening, everyone. Am I audible?
Yeah. You're audible, sir.
So, I would like to discuss this case in the tumor board. And as a medical oncologist, if I feel the patient's performance status is good, there is no ascites, platinum sensitive disease, I will bring this patient to tumor board and will discuss with the surgeons for primary, secondary cytoreduction followed by adjuvant again.
Okay. Dr. Abhijit, are you here, sir?
Hello. Yeah, hi. I'm here.
Hi. Good evening, Dr.
Good
Abhijit.
evening. Good evening.
I think two panelists have said that probably good performance status, not a lot of
Yes,
disease, like we don't have a extensive peritoneal disease or something like that.
correct.
Any difference in opinion? Like, if are there any scenarios where in a secondary setting, in a relapse setting, you would consider a sort of a new adjuvant approach followed by a secondary cytoreduction? Do we have such kind of a scenario that exists where you would like to consider? I
Sorry.
understand that for most sites,
Hmm.
secondary cytoreduction, as Dr. Rahul was very rightly mentioning, that we have few trials which answer this question. But I think in our clinical situation, we often face this situation that you have, say, a 2-year relapse, a 2-year platinum-free interval, very good response to chemotherapy. You have just a few deposits that are seen, and you have treated it with paclitaxel again, or maybe a lipodox carbo again, and there you are wanting that, okay, let's do a surgery again. Any such kind of a scenario exists, and what will be your take? Like a secondary cytoreduction after exposure to neoadjuvant.
In this scenario, of course, if the CA-125 levels are not again in the 300, 400, 500 range, and of course, surgically, we look at the scans, if the ureter and all is free, then this looks like fairly we should go ahead with the secondary cytoreduction. But of course, I would repeat CA-125, assuming that has already been done, and that is on the lower side. And if the scan findings say that we can go ahead with a fairly uncomplicated cytoreduction, then yeah, I would go for it.
Okay. No, my question was slightly different. Like, I'm not talking about this case. We have had a couple of discussion about this. Like, suppose this patient is having peritoneal disease at other sites also. She's
Correct.
not fitting into that OR score
Yes,
and your I model
yes.
prediction model. She's not
Yes.
fitting into that.
Hmm.
And you have given a neoadjuvant therapy. Patient was a TFI of say 2 years,
Yes.
and she's had excellent response. Her CA-125 has come down to say 56, and
Yes.
her mass is reduced after 3 cycles of platinum-based second line chemotherapy. Would you consider a secondary cytoreduction at this point?
Yeah. See, right now you're talking about on the second recurrence, there was
Recurrent
significant
setting. Yeah,
in the
recurrent
recurrent
setting.
setting. In this recurrent setting, there was significant peritoneal disease. So we again ended up giving her paclitaxel,
Whatever second line. Yes.
yeah, or whatever it is, second line. So after 3 cycles, if she has good response with the CA-125 only 56, I would offer her a secondary cytoreduction rather than going ahead with further chemo right now.
Dr. Piyush, your take on this case, like you can see on the screen, and suppose if this patient was say a TFI of 2 years, and you ended up giving chemotherapy first because of peritoneal disease, and she has had an excellent response to chemotherapy. So would you consider secondary cytoreduction at that point?
So secondary cytoreduction, yes, upfront in this case, if in case the patient is in good performance status, low ascites, and low volume, as you have mentioned over here. So
Right.
yes, I would, if the surgeon is, willing and ready to go ahead, yes, upfront and thereafter chemotherapy. The second scenario that you said that, peritoneal disease. So desktop trial also included patients where there were patients for neoadjuvant. Probably we'll have to go that way as well. But yes, each modality is important, and therefore secondary cytoreduction would find its place probably after 3 cycles
Okay.
in the second scenario.
Dr. Rahul, coming back to you again, the second case, that's the second scenario. That after exposure to neoadjuvant, do you routinely take those patients for secondary cytoreduction?
So I actually primary is two factors. One is what is the patient's ECOG status or the physical status at that moment, which is very important. And second, I think was also a prediction that whether we can achieve R0 resection in that setting. If we are not able to achieve, or if the patient is not in a good physical condition, ECOG 2, 3 in that category, then we don't go for secondary CRS in those settings. So I think the primary goal for us is to achieve R0 if we go in again. So if that is filled and if the patient is actually fit to tolerate the procedure, then only we go forward and then the benefit is there.
Okay, so I'm just discussing cases which we actually see in our common practices that we do encounter such cases where we started chemotherapy, good response. We are very tempted to do surgery like that. So basically, what a surgeon's opinion is that if the patient has achieved a very good response, and similar to the scenario in the upfront setting, that if the surgeon sees that okay, R0 resection can be done even after exposure to neoadjuvant chemotherapy, despite the patient having some diffuse peritoneal disease, you can still consider the patient for secondary cytoreduction. So, what if this patient was BRCA positive? Do we have any data? I think I can go to Dr. Keshav and then Dr. Piyush that if the patient was germline BRCA positive, so this is December 2022, probably not a very good access to your olaparib and everything, and I think most of the trials they have not addressed the BRCA status. So, what will be your approach there? As far as this referring to a surgeon is concerned, Dr. Keshav, if I may start with you, please.
If a patient has received upfront secondary cytoreduction, then it's
No,
okay.
upfront the patient has received this and she has relapsed and she is BRCA positive. Now you have information that okay, the patient is BRCA positive. Would you consider for upfront surgical secondary cytoreduction here also if BRCA is known?
Yes. If secondary cytoreduction is possible, then if R0 resection is feasible, then that has a huge survival benefit. If R0 resection is not feasible, then that's a different ballgame. And then again, platinum-based chemotherapy followed by PARP maintenance, plus minus bevacizumab.
Okay, great. Dr. Piyush, your approach, sir, and what will be your adjuvant? And Dr. Keshav addressed this thing that what would be your adjuvant approach also? Suppose you offer surgery for this case.
Yeah, so if in case surgery is being offered, surgery, of course, yes, and this patient has not received olaparib, then she receives olaparib in a maintenance scenario if she's BRCA positive after chemotherapy is done, after the second line chemo. So
for BRCA, you will still offer a surgery for every patient. I think it is not supported by any trial. Would you still be keen?
So if I talk about the trial for major trial was desktop, you will see the what was the recruitment period, that was 2010 2014 somewhere it was initially done. Now where are we probably trying to fit in those blocks actually for BRCA over there? No, so we'll have to actually see the best sequences of any patient, any relapsing recurrent diseases to actually involve all the modalities as much as possible, and then take the sequencing is the key word. So I would say that not to miss any modality rather, and for the reason that the data is missing over there, for that I wouldn't leave that modality.
Right, sir. Very nicely
think,
summarized.
Yeah, Abhishek, I'll come here. I think if you look at all the three major trials for secondary cytoreduction, I think none of the trials have actually addressed this, that whether if the patient is BRCA mutation, whether the secondary CRS helps or not. And
Right.
out of the three, two are positive for secondary CRS, and one is negative, which is the GOG 213. I think there
2 and
were
3.
differences in that because it didn't have a score and, it was too much on the surgeon's discretion. But the only factor, I think, there is one trial with secondary CRS and HIPEC versus no HIPEC. There, the benefit of HIPEC was not there in BRCA
Yeah.
mutant patients. So I
Very
think
right. So
HORSE or
basically,
CHIPO, I think some trial is there.
I was about to come to that only, that whether you go for the CRS or you consider HIPEC, and what are the situations where HIPEC can be utilized. If you can probably highlight more on that, sir.
Yeah, so I think on platinum sensitive recurrences, I think I know about there is a recently which was a published trial, CHIPOR trial, which happened where they did after 6 cycles secondary CRS and HIPEC. That was a positive trial, but I think the paper hasn't come and I have not seen data whether they have addressed BRCA mutant versus or HRD positive versus HRD proficient and BRCA negative patients. There is no such data. But there was a small trial, I think HORSE, I think the trial's name is. So there, I think they didn't find benefit. There is a post hoc analysis of that subgroup. So the benefit was not there, and it was a negative trial because the majority of patients in that group were actually BRCA mutant or HRD positive. So there, the benefit of HIPEC didn't come with secondary CRS. But there is no such trial, surgery versus no surgery, but it is surgery plus HIPEC versus surgery alone. So
Alone.
that's the
Yeah.
difference we have when it comes to BRCA status.
Right. So, just coming back to our medical oncologist, Dr. Piyush, let me start it with you. That suppose a patient has relapsed, it has come to you for the first time. She was treated elsewhere. Let's suppose in this case. So, are you doing? Suppose she has undergone this secondary cytoreduction. You've given some cycles of chemotherapy. So are you routinely doing BRCA or HRD? What is your approach to molecular testing in this case, and how you are offering PARP inhibitors in this, all comers or some selected few population only?
So if it's a relapse scenario, most of the times we actually are doing only BRCA is what we see rather than the HRD at a later stage. So I'm not seeing HRD at a later stage. So
Right.
I see BRCA, and if BRCA is positive, then I would admit that I would rather look at a relatively broader gene panel, not just BRCA 1 and 2. So I would also look at
ATM check.
yes, that as well. But having said that, it is the BRCA 1 and 2 that where the maintenance would start. If in case there is a check 2, I would discuss with the patient. But yes, that's what it is. Not the HRD.
Okay. Not the HRD, sir. I think initial, doctor, let me take opinion from Dr. Keshav, then we can have another small discussion about it. Dr. Keshav, what will you do?
So if I have not done in the frontline setting, at relapse, my practice is to do HRD testing, and so that we can offer them PARP inhibitor. And if that is BRCA1, BRCA2 positive in somatic, then we offer germline also. But first we do HRD.
Even in the relapse setting?
Right, even in the relapse setting.
But I think, like Dr. Piyush was mentioning, for most of
right.
the
I know we can
most
give
of the
without
trials, we have data for germline
right,
BRCA only.
But just for the purpose, if we have not done in the frontline setting, then we are used to offer them in the relapse setting.
Yeah, right. So we have slight difference in opinion. I think data is supported, but on a case-to-case based discussion, I think we can discuss with the family that if the patient has a very long relapse initially, and I think initial approval was for all comer patients, that they used to give rucaparib as well as olaparib as a maintenance for every platinum sensitive disease. But I think now even NCCN says that it is not beneficial for every patient, probably only for germline BRCA. They don't include HRD in that, but it's quite fair that if the patient has a HRD positive, very long platinum free interval, I think we can have a discussion, one-to-one discussion regarding that. I have a small case for the same in the subsequent slide, so maybe discuss about that also. So quickly moving on, So I think we have discussed this. We have discussed about the AGO over score, which was there in the desktop trial, and we have all been following that. We have had three trials, out of which two are positive, one is negative. One was the Chinese trial, which was your SOC1 study, which was published in Nature, I think. And then the important thing is, I think we should always discuss these cases in the tumor board meetings, and then only take a call. So, Dr. Abhijit, a quick question. Any role of cytoreductive surgery in platinum-resistant setting? Any situation where you will consider that?
In a platinum resistant setting, only if it is a very, very small disease, we can think about it, but the prognosis is going to be bad in any scenario. That we can all agree on. But within 6 months, a recurrence is very difficult. It's usually we end up going for a second line.
Dr. Modi, any difference in opinion in platinum-resistant setting?
Yeah, I think even I'll actually look at the quality of the first surgery. I think if it was done at a very good center and, they have done a proper R0 resection, I don't think there is enough data to support, doing a secondary CRS in a platinum-resistant setting. But if the first surgery, if it was not done in a quality center or in a, in a good tertiary level cancer care center, I can still think about, considering the status and the feasibility of R0. Then I can think. But if a very good center and if the patient has recurred fast, I still doubt about my thing of going in back.
Yeah, I think I agree with both of you that in platinum-resistant setting, it's more like a very far-fetched thing and probably giving a false hope to the patient that we are going to resect those patients. We don't have a very good data to support about the role of secondary cytoreduction in platinum-resistant setting. Quickly moving on, I think we have all discussed this is the SOC1 trial. The first one was the desktop trial, and they are all very carefully selected patients. We should be very careful in selecting our patients before doing this was a negative trial that you are mentioning. So this is what NCCN suggests, that where you all have to consider the secondary cytoreduction, good performance status, no ascites, isolated or limited foci of disease with a good platinum-free interval. So I'll just quickly move on to the second case because I think we have limited time. This is a case I have been treating this patient for the past 7-8 years. So she's a 60-year-old female from Nepal. She presented in 2019 May with stage 3C ovarian cancer, upper abdominal disease. She was treated with paclitaxel. She underwent CRS with HIPAC. It was an R0 section. She completed adjuvant. And she was germline BRCA positive, BRCA1 positive. She completed adjuvant olaparib for 2 years. And then she again relapsed in 2021 December with peritoneal disease. And it was minimal disease. She was given an option of secondary cytoreduction, but she did not opt for it because her surgical course was quite complicated. So she was just treated with paclitaxel 6 cycles. And then she was treated with, again, a discussion happened because she had a very good response to Ola. So Ola plus Bev maintenance was given. So Dr. Piyush, let me come back to you. Role of olaparib or arucaparib re-challenge in a patient who has relapsed after 2 years or 3 years of PFS.
I think so. This is the classical case that you presented where one would actually, consider re-challenging, where there was a good platinum-free interval. Initially, also the patient had completed the olaparib, and after stopping it, there's been a relapse. So, of course, one can actually consider, and it's a small disease relapse which is happening again. So
It was a small disease relapse. I've not shown the imaging and all, but from my memory, it was not a very.
Yeah. So I think so. This is one particular scenario where olaparib re-challenge could make a case, and I think so. There has been a trial recently. I'm not recollecting that, which has shown that you have positive effects on re-challenge. I think so.
Yeah, it's a PFS
PFS benefit was still obtained.
Yeah. Dr. Keshav, would you like to re-challenge olaparib or just change the PARP inhibitor and would like to continue after patient has achieved a very good response? Near CR after paclitaxel in a relapse.
After very good response, we used to offer PARP inhibitors again. We used to re-challenge, but our practice is to change the PARP inhibitor. We generally, if we have given olaparib, then we give rucaparib. If we have given rucaparib in the front line, then olaparib. And there is some PFS benefit is there. There are some data, and it is proven now that re-challenge can be done in initially good responsive patients.
Anyway, so I convinced her for olaparib. I also added bevacizumab because previously she had not received it.
Right.
Again, she came.
So,
saying
Dr.
back
Abhishek,
pain
sir,
was there.
excellent discussion. I'm sorry I'm interrupting. You have just 2 minutes to
Just
conclude, sir.
last discussion with two of my medical oncologists. It's a difficult case. So, anyways, she had persistent cytopenia which she never had before. So she was found to have actually ended up doing a bone marrow, and she is now having MDS with deletion 7q, intermediate risk. Anyways, I treated her with azacitidine, venetoclax for 2 cycles. She's gone into remission. So how to manage right now? She has a CA125 of 155. She has disease at spine again. She's having some pain. So by now I understand she's not got a very aggressively spreading ovarian cancer. But in the past 7-8 months, her CA125 has risen from 55 to 155. So how will you manage here? Dr. Piyush, and quick word from Dr. Keshav, both of you, that the MDS has gone into remission with as and when.
So we can continue azacitidine, and we can give some OMCT like endoxan, or we can give, if tumor is strong hormone positive, we offer them hormone treatment also, and latrozole or some fulvestrant. That is not going to suppress our bone marrow.
Okay. Dr. Piyush, your take, sir?
Difficult scenario, Dr. Abhishek. So, I mean, hormonal therapy is something what doctor rightly said, and that could be something, beating around the bush. That's what I can say. That not a easy call. I mean,
So, anyways, I've started her on oral azacitidine maintenance and given her tamoxifen because she's ER positive, and her liquid biopsy has suggested a TMB of 30. So I've told them that probably if you don't respond in the next 2 months, I will consider Keytruda as a off-label thing with continuation of oral azacitidine. So let's hope how she does.
yeah.
So I think with that, I'll conclude my talk. It was very nice to hear opinions from every one of you, as usual. Dr. Piyush, Dr. Keshav, Dr. Modi, Dr. Abhijit. Thank you so much for a good discussion. And Dr. Chaudhary, thank you again for inviting me for this discussion. Thank you. Good night.
Thank you.
Thank you so much, everyone, for the panel discussion. We'll move forward for last talk of the day. For this, we have Dr. Nagin Sharma, sir. Sir is Principal Consultant Medical Oncologist, Max Super Specialty Hospital, Delhi. And this session is sponsored by Glenmark, and sir will talk on management of CINV. So over to you, sir.
Thank you very much for the kind invitation. So I was the person who started the first presentation yesterday, and I am the person who's going to do the last presentation today. So I will come straight to the point. New edge in the management of chemotherapy-induced nausea and vomiting, and where are we as of now? Is there any new changes which have come in or any updates as far as the chemotherapy-induced nausea and vomiting is concerned? So what do you think is the most feared side effect of chemotherapy? So we all know that most important thing in 1983 was vomiting, followed by nausea, loss of hair, thought of coming to hospital, and length of time treatment, which the length of time treatment is going to take. But over a period of time, we have changed that. Over a period of time, it have changed to the fatigue, nausea, sleep disturbances, weight loss, and loss of hair. So but even then, you can understand that the nausea is still considered as the feared side effect of the chemotherapy-induced nausea and vomiting. The patient perceptions have changed over a time. What there are patient ranks the severe CINV near the death, right? So little or no nausea and vomiting, the patients are feeling much better. When the patient is having a severe or delayed nausea and vomiting, major times they are as severe as that it's better to die rather than to consider this much, they undergo this much nausea and vomiting. The severe uncontrolled nausea was considered close to death, right? This is what we all have witnessed. So poorly controlled, the acute and delayed CNV both are deadly many times. The nausea and vomiting are two of the most frequent and troubling side effects the patients experience during the chemotherapy, interfering with the compliance with cancer therapies and quality of life. Most important thing is that delayed nausea was a problem for up to 82% of patients receiving the chemotherapies, which are highly immunogenic or moderately immunogenic, and was typically worst on the day 3 and still persist as unmet medical need arises. Even in those who are not having any acute CINVs, delayed CINV impacted daily life by 23% of the patients. The development of delayed CINV was a more significant problem than acute, with as many as 33% experiencing delayed vomiting and 62% experiencing delayed nausea. However, as many as 38% developed acute CINV and 64% developed delayed chemotherapy-induced nausea and vomiting. The efficacy of commonly used antiemetics, we all know there are multiple studies which are done for apripitant, the fosfoapripitant, but there is a suboptimal control of the delayed phase of CINV. This is what we have witnessed for last couple of decades. So CNV prevention from the latest drugs and now what the new outcome is that the presence of CNV is in the first cycle of chemotherapy is strong predictor of CNV in the subsequent cycles. Point number 1. Therefore, the best available antiemetic prophylaxis should be administered starting from the first course of chemotherapy to maximize the prevention of CNV from the start itself, right? So if the patient is having a CNV in the first event, they are 6.5 times more likely in the second cycle also they are going to have, and this is 14 times more likely that in third cycle and onwards they are going to have nausea and vomiting again. So emetic reflex, we should know. There are some neurotransmitters which are involved, like histamine, the GABA, the dopamine, the substance P, the serotonin, acetylcholine, endorphins, and cannabinoids. So the NK1 RAs, they basically act on substance P, and the 5-HT3 receptor antagonists act on serotonin. This is what we have to understand by and large. What is the new edge of CNV management in today's era? So answer is the nitipitant 300 mg only available fixed combination antiemetics, the next generation NK1 receptor antagonist, selective NK type 1 receptor antagonists with a competitive binding and blocking of human substance P receptors, and there is a high, that is 90% receptor occupancy, long lasting, that is 96 hours brain receptor saturation after first oral dose. The higher binding affinity and longer T-half than the other 5-HT3 antagonists, and selective for 5-HT3 and exhibits distinctly different receptor binding, allosteric binding, and positive cooperativity. This results in long-lasting inhibition of 5-HT3 receptor functions. So new agent CNV, remember that fosnipitant, the next generation NK1 receptor antagonists, a water-soluble phosphorylated prodrug of nitipitant 235 mg IV demonstrated bioequivalence versus oral component of NEPA, that is 300 mg. High, that is 90% receptor occupancy, long-lasting, that is 144 hours brain receptor saturation after a single oral dose. The higher binding affinity and longer half-life than other 5-HT3 receptor antagonists, selective for 5-HT3 and exhibits distinctly different receptor binding, allosteric binding, and positive cooperativity, results in long-lasting inhibition of 5-HT3 receptor functions. The pharmacologic rationale for this drug says that NK1 receptor internalization, there is a synergistic action when used together on internalization. There is a complementary PK profiles. There's no interactions observed between the two drugs. As complementary sites, 5-HT3 peripheral pathway predominant in the acute phase in CNV and substance P in delayed phase, effective control of CNV is there. While in guidelines, adherence is very, very important, and potential to improve adherence to antiemetic guidelines is always mandatory. And there is a convenience. Why? Because there is a reduction in the number of antiemetic doses and the potential to reduce the mistakes in the CNV prophylaxis. So this is recommended in 2023 antiemetic prophylaxis guidelines in the highly emetogenic parental anti-cancer agents for both acute and delayed nemesis prevention in nipitant and post-nipitant. Both are involved. Oral and IV both are approved from 2023 onwards. For moderate emetogenic parental anti-cancer drug for both acute and delayed, again, this is approved. The unique points with IV formulation is that fosnipitant, that is 225 milligram of water-soluble phosphorylated product nipitant plus phenylacetate, which is 0.25 milligram, comes in considered for solutions for infusion form and does not require any reconstitution. IV NEPA does not require any surfactant, emulsifiers, or solubility enhancer, and contain no allergic excipients, minimizing the risk of infusion-related toxicities. So first fixed IV antiemetic combinations, the safety and efficacy compared to oral NEPA. So remember that the dexamethasone can be added to IV NEPA or infused simultaneously, has proven safety and efficacy with fewer injection site reactions and unique significant higher CR rates during extended oral phase compared to conventional IV antiemetics, provides additional convenience to the healthcare providers and patients. So the oral drugs, there are multiple trials which are done by different authors, and they all have shown that this drug combination, the oral NEPA and phosphorotant, both have done well. The complete response to acute vomiting is seen in over 93% of patients by Vaswani B, 97.3% in Vaswani B et al, and other also have shown the similar responses. Delayed also, these have shown much better as compared to the competitors, right? Overall, by and large, no nausea is seen in 77.5% of the patients as far as Vaswani B is concerned. So what about other trials? They have shown that when we are using aprepitant plus dexa or odensetron, highly emergent, they have shown a minimal effect, but when you're using NEPA plus dexa, they have shown a very good response. As you can see, there's a complete response many times. So effectiveness of NEPA, an oral fixed dose combination of nicotinamide and palansitron in prevention of chemotherapy-induced nausea vomiting. Post-analysis also done, and that also have shown that the severity of nausea was assessed using a visual analog scale. The no significant nausea, less than 2.5 on VAS scale, moderate to 0.5 centimeter to 7.5 from VAS scale, and severe nausea 7.5 to 10 centimeter from the VAS scale, right? And this have shown that the anthracycline cyclophosphamide, that is 36.16%, was the most commonly used highly emergenic chemotherapy, whereas FOLFOX was moderately emergenic chemotherapy. In overall, the acute and delayed phase, no severe nausea was reported in majority of the patients, respectively as shown in this picture. So NEPA was found to be effective and well tolerated in preventing nausea in patients receiving highly emergenic or moderate emergenic chemotherapy regimens, with almost 90% of patients responding to no nausea in the real world setting, Indian setting especially. The clinical scenario also have shown the same thing, that this drug works better, and their patients are not having any.
Dr. Nagendra, sir, excellent discussion.
I'm just
Last
coming to the
1
last
minute
slide, sir.
for your conclusion, please.
Right, I'm just coming to the last slide only. So, although therapy was evolved considerably over past 4 decades, 60 to 80% of the patients still experience CINV alongside chemotherapy. Healthcare providers must be aware of the new guideline recommendation along with the safety and efficacy data on the antiemetic regimens, and successfully incorporating these evidence-based strategies and effective therapies into the clinical practice is critical. New agents such as NEPA, with strong Indian evidence, along with 4 drug combination regimens, have improved the control of the acute and delayed CINV, and better prevention also improves the rate of anticipatory, refractory, and breakthrough CINVs. IV NEPA is a new edge in CINV management, which is as efficacious and safe as oral NEPA and superior to other conventional IV antiemetics, and will be ideal in therapies where IV antiemetic is indicated. Thank you very much for patient listening. Over to organizers, please.
So thank you so much, Dr. Nagendra Sharma, sir, for such an eloquent presentation. Now I give the floor for the final comments to Dr. R.K. Chaudhary, sir. Dr. Chaudhary, sir, good evening once again, and over to you for your final comments, please.
Thank you so much. Thank you all the participants. Thank you all the speakers. Yesterday we discussed about the GI cancer, GU cancer, and lung cancer. And there was the excellent talks by Dr. Shyam Agarwal and Dr. Rajat Shah, apart from the other speakers. Today we discussed about the breast cancer, and a good talk by Dr. Bhatia from the Onquest. And at the end, there was a very beautiful talk by Dr. Nagendra. Dr. Nagendra opened our webinar and stayed till the last call. Thank you, Dr. Nagendra. I would like to thank all my participants and all my academic partners. Without their support, the conference would have not been possible. And I would like specifically by name all my academic partners: Tarosh, AstraZeneca, Lupin Oncology, Fresenius Kabi, MCure, Intas Oncology, Aris, Otsuka, Onquest Laboratories, Glenmark, Cipla, and the Tatar Genetics. At the same time, I would like to thank all my tech support team, my organizing partner, Mr. Tarun, and his team. Thank you so much, all the participants once again. See you in the next webinar or maybe physical conference.
So thank you so much, Dr. Chaudhary sir, for giving this opportunity from the organizing team, my colleagues Aram, Yashika, and the tech support team. Thank you so much. Stay safe, stay blessed. Till we meet again. Thank you and good night from all of us.
Thank you. Thank you. Good night. Good night to